slide's a little bit facetious in that it just happens to be a film with the same name as our hit, which was useful. But actually I thought it illustrates a good point, is how do we perceive a threat in our environment? And obviously we perceive these people as a threat, but what about vaccine-preventable diseases? Actually there's a complacency that we can have about them as we don't hear much about them. So if you think about measles, that's something that was a big problem in the past, but in Europe it very much died away and people began to feel quite complacent about it. But actually it's back. And there's been a big outbreak in Europe, whilst the rest of the world has kind of got their mortality rates down from 1 million a year of deaths from measles down to kind of 100 to 200,000 deaths a year. Actually what are we doing in Europe? We're completely failing and we're allowing measles back in. So we've seen large outbreaks over 2012, 13 and 14 with complications to health and deaths. Whooping cough as well, that was a huge problem and died away due to really good vaccination, but actually it's beginning to come back, and that's not due to poor vaccination rates, that's just a change in the epidemiology of the disease and vaccine efficacy waning. So again, what do we do about that, and how do we ensure that our population is kept safe from this threat? So Bristol itself has some very specific challenges around this. We've got kind of quite a highly mobile population. We have children coming in and going out with different immunisation health records. We've got kind of an ethnically diverse population, and we've got huge socio-economic variations, which the last hit was talking about, and just massive changes. And you also place that against the problem with the immunisation schedule itself. It's changing all the time. This year there are some huge changes, but that's likely to be an ongoing process. That every year the schedule that we're trying to deliver is changing, and sometimes at quite short notice. So how do we have an infrastructure that can actually tackle those challenges? And the environment in health services, I'm sure you all face that, but in our hit it's a huge problem that the people who are delivering the vaccines don't know whether they'll be delivering them next year. Yes, in GP surgeries it's fine, but in schools it really isn't fine. Bristol has some really significant issues about delivering vaccinations that I don't think other areas face. And when you try to talk to people and engage them in the hit and the work that we're trying to do, they say actually we're just trying to produce, to deliver our own services for the next year. And how can we kind of imagine expanding? How can we imagine providing things in a different way? But what do we want to see as a hit? We want a service that is innovative, that's kind of flexible, that's able to respond, because actually infectious diseases change quite quickly. Vaccine-preventable diseases come back. You need a service that can change quite quickly, so you can deliver pertussis vaccinations in pregnancy as you see it arise, not 5 years later when you've submitted the right bid to the right CCGs and balanced them. It has to be a flexible, innovative service. And also we're a centre of excellence for research. We're producing amazing vaccination research. And how can we be so behind in delivering those vaccines once we've been a city that's helped developing? So we know what we want, and we've developed within our hit, three sort of streams of work. And the first one is around data. As you know, the Child Health Service has data around who has been vaccinated. And in Bristol it happens to have been set up to only go up to age 5. So there was reasonably good data to age 5. But actually vaccination goes all the way up, and what happens after 5? So our first stream was we need the data to be good. We need to know who has been vaccinated and who hasn't been vaccinated. We need to know which areas there are clusters of children who haven't been vaccinated. So with some funding from BHP and match funding from NHS England, we've put 2 additional people into that database to try and clean the data, to say actually we need really good, robust data. And we want in the future that data to be really responsive, so we can see if a bit of a scandal or a scare arises in a particular population, that we know that quite quickly and we can kind of address that. So that's our first stream of working. The second stream is just about the universal programme. It functions quite well among small babies. Parents are quite good at taking the vaccination, but in teenagers, the rates for completion of the vaccination programme is at best about 40% in Bristol, because it's happening on an ad hoc basis with teenagers expected to make an appointment with their GP. And actually, if you do it in schools, you get coverage rates above 90%. It's a no-brainer. But That's not happening in Bristol, and there doesn't seem to be an easy pathway to make that happen, but that's one of our key aims. Also, there's the vulnerable vaccines. Vaccines that aren't delivered to everyone are vulnerable. They are really ad hoc. BCG vaccination, hepatitis B, and vaccination in pregnancies are really sporadic. And so we see children in the Children's Hospital who've been exposed to TB in a relative, and they haven't yet been vaccinated. And you think that's just silly. You know, we need to be good at this. And we've been talking about it for decades. How can we make that a really robust thing? But we've also got vulnerable populations. We've got asylum seekers coming. We have economic migrants, looked after children, and nomadic groups. And each of those groups and the other groups have specific needs around vaccination and accessing the programme. So all the areas need a specific exercise, and our HIP is attempting to draw different people from expert groups to sort of tackle the problem together. And also to combine it with really good research. We have good research, we've got the clerk, there's plenty available to say what is effective, what changes will make a difference, and how can we maximise that. And running alongside that is the public patient involvement. And I was thinking about, yes, we want people to be involved in saying, you know, how can we make it easier to be vaccinated? What would you think about maybe consent, self-consent in schools for older teenagers? You know, we need patient involvement with that. But also they could be used to help drive, I think, change, to say actually it's not acceptable that the vaccination rate in Bristol is 40% for teenagers, where the rest of the country is 90%. And we use public patient involvement to sort of put pressure to bear. But our HIP's quite new. We're only 9 months old, and I guess we're just starting off coming together to bring people from different organisations. And we have got, I think everyone wants to see the vaccination service improve. Everyone feels quite invested in it. So I'm quite hopeful that we'll be able to bring some change over the next 5 years or so. Thank you. Any questions?
So just to address the question around where it's difficult to have a pathway for teenagers, I think the Health and Wellbeing Board system is exactly the right place to do this. You've got education, you've got public health, you've got CCGs. They can make decisions around where we vaccinate, how we vaccinate, what pathways. So I think, you know, requesting the Health and Wellbeing Board to have a look at that as an organisation, take responsibility for driving that change. Inequality, that welcome would be an ideal thing to do.
Great, thank you.